We can start.
All right, so I request the attention of all the faculties and delegates. I will take a few minutes of yours and let me introduce me and the faculty members of the session. So good evening and welcome to one and all. This is Ankita from Clarnet, the assigned session assistant for a seamless experience. And Clarnet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Planet is very proud to be a digital partner for this event organized by Society of Onco-Anesthesia and Perioperative Care. And topic of today's session is systemic reviews and meta-analysis. Let's begin today's session, for which I would like to invite Dr. Garg to take over. Over to you, sir. Kindly proceed with your talk.
Thank you so much, Ankita, for the initial remarks. I welcome each participants for today's session, which is almost we are coming to the 30th webinar of Society of Oncology and Perioperative Care. Thank you everybody for joining for this type of webinars. And also before we proceed further, it is also to inform that the society is having its own journal and that is running very successfully. This is called Journal of Onco-Anesthesiology and Perioperative Medicine. So you're all invited to submit your papers to the journal, which is through online submission, and you can easily Google it as Journal of Onco-Anesthesiology and Perioperative Medicine. Along with me for today's important session of systematic reviews and meta-analysis, wherein we always think that what is the right way of doing the things. Sometimes when I was younger, I used to believe that there is one study and it concludes that technique A is better than technique B. And I presumed that technique A should be preferred. But then I realized that there has to be more literature, what those more literature are, how to analyze those situations, how to analyze those data, and come forward with some concrete evidence when we talk about the evidence-based medicine is today's topic. And with me, Dr. Priyam Saikia is along with me chairing this session. Dr. Priyam is a great man by profession, by person, and by heart also. He is working at Guwahati Medical College and Hospital. He has special interest in many of the important aspects, difficult aspects, in fact, like ethics, acid-based disorders, and these anesthesia. He has numerous publications, and he has already published a couple of the systematic reviews. I think he is one of the best person to chair this session against from a person who has a wide repute as a speaker today, Dr. Priya Ranganathan. Over to Dr. Priya.
Thank you, Dr. Rakesh Garg. Thank you so much for that kind introduction. Today we are going to listen to Dr. Priya Ranganathan, ma'am. Can we please have Madam's slides, please? Okay. Madam does not need any introduction. She is a professor at Tata Memorial Center, and she has got her interest in thoracic anesthesia, research methods, and biostatistics. Ma'am would be talking on systematic review and meta-analysis. In her talk, we will learn regarding the different methods, what are the things that we need to do, what are the things that we need to understand, and how do we interpret such, such study designs. And with presence of such dignitaries like Rakesh and Madam, I hope that we will have a very fruitful discussion section. Over to you, Priya, Madam.
Thank you. So thank you for that very, very kind introduction and for the opportunity to speak here today. I'm just going to share my screen. Right, is that clear?
Yeah, ma'am, it's clear.
Okay, great.
Yes, ma'am, it's clear.
So in the next 45 minutes or so, I will be talking to you about systematic reviews and meta-analysis. I'm going to just start by defining what is a systematic review, and it's the review of a clearly formulated question that uses systematic methods to identify, select, and critically appraise the relevant research. Now, a meta-analysis actually goes one step ahead of a systematic review. So in addition to systematically identifying relevant literature, we do a statistical analysis that combines or integrates the results of the various studies that you have identified. So this is also known as pooling or a quantitative analysis. So a systematic review is a qualitative analysis, whereas the meta-analysis part of it becomes a quantitative analysis. Now, All of us are familiar with the evidence pyramid, and you know that editorials and expert opinion are considered a very low form of evidence because they're highly biased and the quality of the evidence is very poor. And as you go up the pyramid, you'll realize that case reports and case studies come a bit higher, and then it's cross-sectional studies, case-controlled studies, cohort studies. And right up there, you have randomized controlled trials. And what forms the apex of this pyramid, or the highest level of evidence, is systematic reviews and meta-analysis of randomized controlled trials. And that's why it's so important to have good quality systematic reviews, because they form the basis of a lot of our guidelines and recommendations. So where do systematic reviews fit in with other types of reviews? So you have all reviews, which are known as overviews, which could be narrative reviews, scoping reviews. All of these are non-systematic. If somebody asks me to write a narrative review on a particular topic, I will include articles which match my train of thought, and I will exclude articles which I don't agree with, right? So I'm introducing a bias because I'm only going to present the concepts that I believe in. Whereas in systematic reviews, you have a clear and transparent search strategy, and every article which meets your criteria needs to be included. So it becomes very unbiased and a better way of presenting evidence. Meta-analysis goes one step further, and it synthesizes or pools the results from the studies which are included in the systematic review. So these are actually subsets of each other. Now, why do we need a systematic review? So we know that there is so much information available out there. When you look at PubMed, it is actually mind-boggling the number of articles that are added every day. But the problem is that not only is there too much information, not all of this information is of equal quality. And information does not necessarily mean evidence, right? So you may have case reports, case series, very small retrospective studies, which are not really evidence. And often there is conflicting information. So somebody tells you that dexamethasone prevents nausea and vomiting. Another study tells you that it has absolutely no benefit. And a third study tells you that it actually does harm, right? So which of these should you believe? What a systematic review and a meta-analysis does is it summarizes the published literature. It gives you a very objective summary as compared to a narrative review. It helps you to estimate the average effect from all the available studies. It increases statistical power because when you combine all these studies, your total sample becomes much larger, and therefore you're able to obtain a more precise estimate of effect size. And lastly, it helps to identify research needs. For example, if I'm doing a systematic review on a particular topic and I find either there are not enough studies or there are very small, poor quality studies, that clearly tells me that this is an area that I need to focus on to do better research. So what goes into a systematic review? You have an idea, a burning idea, and you want to ask a question. You go and review the literature and you realize that there is so much evidence that you need to do a review. So you write down the background and you specify the problem. Now, like all other research studies, a systematic review also needs a review protocol. Okay? And this protocol will lay down the methods that you will use in your systematic review, most important being the search strategy. You register the protocol on a registry, just like you would register any other trial. Then you start with the review. So you search the literature and retrieve the relevant studies. You assess the studies that you retrieve to see whether they meet your criteria for inclusion in the review. You do an assessment of the validity of the studies, extract the data. So this is where a systematic review stops. If you were doing a meta-analysis, you would go one step further and synthesize the data. Let's look at each of these steps in a little bit of detail. And the example that I'm going to be using is this systematic review and meta-analysis, which was published in the BMJ in 2008. And this looked at prophylactic administration of parenteral steroids for preventing airway complications after extubation in adults. And it was a meta-analysis of randomized, placebo-controlled trials. So we first start by asking a question, and the question is usually put into what we call the PICOT format, where we talk about the population, the intervention, the comparator or the control, the outcome, and the time point at which this outcome is measured. And the question they asked is, are steroids superior to placebo in preventing laryngeal edema after extubation in adults? And do steroids reduce the need for subsequent reintubations, right? So the population here is adults, the intervention is steroids, the control is placebo. The outcomes are airway complications like laryngeal edema and reintubation, and the time point is after extubation. Next, a literature search is needed. And why is a literature search needed at this point? It is to assess the need for a review. So has this question already been answered in a valid manner, right? So is there high quality evidence to answer my question? Do I need to do a review at all? If there is no high quality evidence, then are there enough studies for me to conduct a systematic review, right? So these are the two things you need to be looking for when you do the initial literature search for your focused question. Now, this question was not answered already, and there were some studies which looked at steroids versus placebo. So they decided to go ahead with the systematic review. They wrote up the protocol. Now, why is the protocol needed? It helps you to plan how you're going to do your review. It avoids duplication, right? So when you go to a trial registry and look at the list of registered protocols, it tells you whether somebody else is already doing this review, in which case you should not be duplicating their efforts. And the third thing is it minimizes bias. Once you have the protocol written, you are forced to follow those exact steps, and you cannot change any steps in the protocol just because you want a particular result or an outcome. And in the protocol for a systematic review, you will include the search strategy, the inclusion and exclusion criteria, and the data extraction methods. So the protocol is written like any other study protocol. You'll start with the title. You'll explain the background of the review. Why are you doing this review? What is your aim? What are your objectives? And then, as I said, your methods will include the search strategy, the inclusion, exclusion, and your analysis plan. Now, when we talk about search strategy, right, that forms the crux of any systematic review. And that is because you have so many different sources from which you can get articles for inclusion in a systematic review. So you have published literature, right? You have citation indexes like PubMed, Embase, Scopus. So all of these are indexing agencies which maintain lists of articles published in various journals. And each journal can choose which of these databases they want to be associated with. So a journal on its website will say it is indexed in PubMed, Embase, Scopus, etc., etc. You can choose which of these databases you want to search. The common ones, as I already mentioned, are PubMed, Embase, Scopus, ScienceDirect, and so on. Second, you can look at abstract databases, right? And these include abstracts published in conferences or published in journals. Next, you look at reference lists. So when you find an article which meets your criteria, you will look through the reference list of that article to find additional articles which meet your criteria. And the last way of doing it is to contact authors. So if you know people who are doing a lot of work in a particular area, you can write to them and say, I'm doing a review and so topic. Do you know anyone else who is working in the same area? And can you share their contacts so that I can ask them about what work they are doing? So all of these are established ways of finding literature. Now, there is an area of literature known as the gray literature, and this is unpublished literature, right? And this includes abstracts and studies which are in progress or have just been completed but have not yet been published. And it's very important to identify these sources of literature, and I'll come to that in just a minute. Another useful source to identify literature is trial registries. So nowadays it's mandatory that if you're doing any interventional study, you must register it on a trial registry like the Clinical Trials Registry of India or clinicaltrials.gov in the US or the WHO Clinical Trials platform. So it's mandatory that any interventional study is registered on a trial platform before the first patient is accrued. And these trial registries allow you to put in keywords and search for trials. So this becomes another very useful resource to identify trials related to your area of interest. Now, why do we need to be very thorough with our search? And that's because we know that statistically significant positive results are more likely to be published. And this is what we call a publication bias, okay? In addition, they are more likely to be published rapidly, and this is known as a time lag bias. They are more likely to be published in an English journal. That's what we call a language bias. They're more likely to be published more than once, and this is called a multiple publication bias. And they're more likely to be cited by others. This is known as a citation bias. And what this means is, if I restrict my search only to English journals and published articles, I will pick up a lot of studies which showed positive effects, which showed that a particular treatment or intervention was effective. But what I will miss is an equal number of studies which were negative, which showed that the particular intervention or treatment did not work, but did not get published. And therefore, when I do the review, I will falsely end up estimating that this particular treatment works very well. Whereas if I had included all the articles, I may have found that the treatment does not actually work, right? And so publication bias is a very, very real thing, and we need to be careful about it when we're doing a review. And this is one of the tools that is used to determine a publication bias. So in a systematic review, we usually include something called a funnel plot. And what this plot does is it plots the error of the study. I'm not getting into the statistical details, but what it plots is the error of the result of the study versus the sample size, right? And you'll realize that at the bottom of the funnel, you have smaller studies. Now, smaller studies tend to be less precise, right? And that is why you'll see that their results are scattered all over the place, okay? But as you go up the funnel, you get larger studies and the results become more and more precise. Now, if you have no publication bias, you should have a complete funnel where you have a number of positive small studies, a number of negative small studies, and then as you go up, it narrows out. But if you have a publication bias, when you plot this funnel, you will find a gap, which means you're missing out on some studies which either gave a positive or a negative result. So you're missing out one section of studies. If you didn't understand all of that, it's fine. Just remember, funnel plot is something which is used in a systematic review to show the presence or absence of publication bias. When you're searching for studies, you need to specify what language are you going to search in. Is it going to be only English? If it's only English, then you must remember that you may be missing out studies published in German or Chinese or Spanish, and that may represent a significant proportion of work. Now, there are practical logistical difficulties, right? So when you have articles in Spanish or Chinese, it's sometimes difficult to access them or translate them authentically. So you may choose to stick to English, but then that becomes a limitation of your review that you used only English articles. What about the time period? So are you going to include all articles from 1965 to now, or are you going to look at articles published only in the last 20 years? Now, all these are open to your, you can modify these as you need. For practical and logistical ease, you may decide to stick to last 20 years, which is perfectly okay. But again, you must mention that in your methods, and you must recognize that as one of the limitations of your study. What types of studies are you going to include in your review? So you know that there are various study designs with different types of bias. There are observational studies, there are analytical studies, there are randomized controlled trials. Are you going to include all of these, or are you going to stick to only one type of study? So is it a systematic review of only randomized trials? Search terms that you use have to be specific and reproducible. And as far as possible, you must use keywords and what we call mesh terms. So mesh stands for medical search headings. And when you go to a database like PubMed, PubMed categorizes all its articles using certain specific terms. And these are standard terms. So for example, thoracic anesthesia, one lung ventilation, double lumen tube. All of these become standard terms, and an article dealing with blockers versus DLTs will be classified under these terms. And this helps with searching, because when you put in one of these standard terms, it quickly retrieves all the articles which were sort of classified under these terms. And this also allows for changes in spelling, right? So some people put double lumen with a hyphen. Some people put double lumen without a hyphen, right? Mesh will take care of all of that. So any combination of words of double lumen will be picked up when you use double lumen as a mesh term. And that's why this is so useful. You can also use Boolean operators. So you can say double lumen and bronchial blocker. So that will pick up all articles which have double lumen and which have bronchial blocker. You could use double lumen and bronchial blocker, not esophagectomy. So that will exclude esophagectomy patients and keep only other types of surgeries. So use of Boolean operators helps you to filter out your search so that you don't get too many irrelevant studies and are able to focus only on studies which may be more relevant to your study. Sorry. So what was the search strategy for this particular systematic review? They searched electronic databases, including PubMed from 66 onwards. They looked at Central, which is the Cochrane Controlled Trials Register. They looked at Web of Science and Embase. And they used various terms, for example, anti-inflammatory agents, or glucocorticoid, or corticosteroid, and so on. And they identified all clinical trials. So they included only clinical trials with no limitation on language, year of publication, or publication status. Next, you need to register your protocol. So once you've written up the protocol, you need to register it. And I already explained why it's important to register a systematic review protocol. This is one of the most common platforms used for registering a systematic review, and it's called Prospero. It's the International Prospective Register of Systematic Reviews. It's completely free, and you can access it through the NIHR website. Now, once you've done that, you can start your search, right? And when you're doing a search, you need to maintain a record of how many articles you initially identify, how many you exclude and for what reasons, and finally, how many you're including in your systematic review. So let's see what happened with this particular review. When they searched the citations, and the initial search is usually done on titles and abstracts, okay? They found 1,500 articles. Now, because they were looking at multiple databases, there were many duplicates. Okay, so an article may have been retrieved from one database and also from another database. And so they excluded 180 articles, which were duplicates, and they found 1320 unique abstracts. Now somebody has to sit and go through each of these abstracts, look at the full text, and see whether the full text actually meets your criteria. So the abstract may have mentioned the word double lumen tube or bronchial blocker, but the actual paper may have nothing to do with a DLT or a bronchial blocker, right? In this study, Dexa and placebo, right? Maybe the abstract just mentioned dexamethasone or steroid or something and got picked up, but maybe the actual article did not deal with this at all. And so when they went through the unique abstracts, they realized that almost 1292 studies were irrelevant and only 28 studies were of potential interest to them. This particular step is ideally done in duplicate by two separate independent reviewers to minimize bias, and then their findings are sort of tallied and resolved. Now, when they looked at these 28 studies in further detail, they found that 15 were actually not randomized control trials. So there must have been some problem with the way the study was indexed in the database. It got picked up, but it was not actually a randomized trial. 6 of these were actually reviews, 8 were just commentaries, and 1 was not even a human study, it was an animal study. And so these 15 got excluded, and they were left with 13 randomized control trials, of which 7 were in children. And so finally, they ended up with 6 randomized trials, which were in adults and which met all their eligibility criteria. And this is what typically will happen in any systematic review, that you will start with a huge number of abstracts, but when you gradually go through them and go through the full text and go through all the eligibility criteria, you will be left with a very small number for data extraction. Now, a systematic review is an amalgamation of different studies, and therefore the quality of each individual study is going to affect the validity of your systematic review. And what we say is a systematic review is only as good as the trials or studies that it includes. So you need to assess the quality of each of the studies that you're including in the systematic review. And you have to do this using a structured format. And what are some of the things we look at when we talk about quality, right? Now, if you're looking at a randomized trial, right, we're worried about something called selection bias. So was the study actually randomized, and was this randomization done properly? The second thing is performance bias. Okay, so were the groups of participants treated equally? Was it that one group got preference and the other group got some inferior additional treatments so that this group performed better? The next is attrition bias. Were all participants randomized accounted for in the analysis? Were there any withdrawals, losses to follow-up? Detection or assessment bias. So was there a blinded assessment of outcome? And finally, how was the analysis done? Was it appropriate for the study design? And these are some of the things which can bias the results of a randomized trial and therefore need to be accounted for when you look at the quality of the trial. One of the oldest tools to assess the quality of a randomized trial was something called the Jadad scale. And this has subsequently undergone several modifications. So you have multiple versions of the Jadad scale now. And this took into account 3 main factors: randomization, blinding, and withdrawal. Okay. And there were points given depending on how good or bad each of these factors was in the study. So a study could score anywhere between 0 and 5. Now we have better tools. The Cochrane group has come up with something called the risk of bias tool. And again, this has undergone various editions. So right now what we're using is the risk of bias tool, or ROB2 it's called. And this again looks at various aspects. So how was the randomization done? How is the allocation concealment done? How is blinding done, right? And for each of these points, for each study in the review, you could put a minus if it was absent, a plus if it was present, and a query if it was unclear whether or it has not been reported properly. And depending on this, each study gets a score. So you know whether the study was high quality, low quality, average quality. There are various other ROB tools, risk of bias tools. So you have tools for non-randomized studies, that's called the Robbins I. You have for non-randomized studies of exposure, that's called the Robbins E. And then you have missing evidence Robbins, so that's called ROB-ME. You can just go to the Cochrane website or the ROB website and check this out. Each of these tools has a checklist and a tool kit to tell you how to score studies. If you're looking only at observational studies, this is a slightly different tool. It's called the Newcastle-Ottawa scale. Again, it has structured questions that you answer for each study, and it tells you how good or bad the study was. Okay, so the basic thing is you need to use some kind of a structured format to assess the quality of studies in your review. Now, if you looked at the DEXA study, they chose the Jadad scale, and for each of the studies, the 6 studies that they included, they gave a Jadad score. And you can see that 5 of the studies scored very well. But one study seems to be a poor quality study because it did not have blinding, it did not have proper analysis, and even randomization seems to be uncertain. After this, we start extracting the actual data. Okay. Typically, what we would be interested in is the publication year, the year of performance of the study, the name of the author, of course, the study design, if you're including various types of designs, the characteristics of the study population. So what was the number, sample size, what was the age, what was the gender, what setting was the study done in, right? What were the outcomes or assessments that were done? What were the results? And what other factors did they look at? You could add or subtract any more factors that you want data on, but you make a standardized data extraction sheet and you start extracting the data. So for this particular study, this is what they did. You can see over here, they've got the name of the study. Okay, this is the steroid group and this is the placebo group. This is the study population. So this particular study looked at patients with pneumonia, hemodynamic instability, post-operative patients, neurological patients. This is the time point at which they measured the outcome. This was the mean age with standard deviation. This is the sample size. This was the intervention, and these are their outcomes. Then they go on to the second study, and so on for all the studies. So this is their data extraction sheet. Now, if you were doing a systematic review, you would stop at this point and you would say, we found 6 studies which met our criteria. 3 of these studies looked at patients with pneumonia. 3 other studies looked at patients with XY, okay? And 3 studies found a difference, 2 studies did not find a difference, and that is where the systematic review ends, right? But now you're interested in doing a meta-analysis, which means you're interested in synthesizing or pooling the results. So when can you pool the results of studies in a systematic review? Obviously, you need more than one study, right? So you need at least 2 studies if you want to do a meta-analysis. You need studies where there are no substantial differences in the study characteristics. Okay, so the types of patients, the types of interventions, the types of outcomes have to be similar. Otherwise, there's no sense in comparing them. The outcome has to be measured in a similar way. So if one study has measured pain using a scale of mild, moderate, and severe 1 week after surgery, and the second study has used a numerical rating scale and measured it on day 1 after surgery, then there's no sense in comparing the 2 because these are different scales, different time points, and you cannot really pool these. Obviously, complete data on all your studies has to be available. Now, meta-analysis has certain principles. Patients in one trial are never directly compared with patients in another trial. So it's not that you add up all the patients on the intervention arm across 6 studies and all the patients in the control arm across 6 studies and just compare them together. You don't do that. You analyze each trial separately. You gather the summary statistic. When I say summary statistic, I mean the result of each trial. What was the odds ratio, or what was the mean difference, right? So that data you get from each trial, but then for each trial, you give a certain amount of weightage and you pool the results so that some trials contribute more to the final result as compared to others. And these summary statistics will be added together to give you your meta-analysis. Now, what do we mean by summary statistic? We know that when we analyze data for dichotomous data or binary data, or data which can just take two outcomes, right? Smoker, non-smoker, dead, alive, vomited, did not vomit. These are all examples of binary data. Here we talk about terms like relative risk, odds ratio, or risk difference. Whereas for continuous data, blood pressure, blood glucose, right, urine output, this is continuous data, and here we talk about the difference between two means. When we talk about weighted average, when we say that the summary statistics were weighted to give the final result of the meta-analysis, what we mean is the results of some studies make a greater contribution to the total. And usually we will give more weightage to studies which give us more information. And which studies give us more information? Studies which are larger, which means sample size becomes your main factor, and studies which have more events. Okay, so these are the two main deciding factors in telling us how much weightage should be given to a particular study. So when we decide to do the meta-analysis, you will come across something called a forest plot. And it's called a forest plot because it looks like a forest of lines. So that's why it's called a forest plot. How do you read this, right? So these are the names of the studies included in the meta-analysis, and it's called the study ID. So this is the study by Cheng, which was done in 2006, and Dauman in 1992, and so on. These are the two groups. This is the steroid group, and this is the placebo group. This is the outcome for which this graph is being drawn, and this particular outcome represents the number of patients with laryngeal edema out of the total number of intubated patients. Okay, this is the data for each study for this particular outcome. So in Cheng's study, 8 out of 85 had laryngeal edema in the steroid group, whereas 13 out of 43 had laryngeal edema in the placebo group. This is the odds ratio with confidence intervals for this particular study. Okay, and so on for each study. Now you can see that each study has been given a particular weight, right? And so this weight tells you how much is this study contributing to the final result. Okay, this was a fairly small study, right? 85 patients and 43 patients, but it had quite a few events, 8 and 30. So it's contributing 17% of the total result of the meta-analysis. This is a huge study, 300 patients, but the number of events is not much more than the previous study. It's just 11 and 17. So this is again contributing just about 19%. Okay, and so on for each study, so that the total becomes 100%. So what this weight tells you is what is the weightage given to each of these studies in the final meta-analysis. You can see that each of these lines has a box and a line, right? The box is the odds ratio for that study, and the size of that box is the weightage given to that particular study. Okay, now because this is a small meta-analysis, you're not seeing too much of a difference in the size of the boxes. This final diamond is the overall result of this study. So each of the studies had a particular odds ratio, and when you pooled all the results, giving them this proportional weightage, the overall odds ratio was 0.38 with odds confidence intervals of 0.17 to 0.85, which means overall steroids reduce the odds of developing laryngeal edema. Now, in an ideal meta-analysis, you would want all studies to have the same intervention, the same type of participants, the same outcome measure, the same time point, and the same or similar results. But that does not happen, right? In real life, when you do a systematic review, you will find heterogeneity or differences between studies, right? So the studies may be looking at the same thing, steroids versus placebo, but there may be what we call clinical heterogeneity, which means the participants or the setting or the outcome are different. So one may be done in blacks and one may be done in Asians. One may be done in a tertiary cancer center, the other may be done in a rural hospital in a smaller part of the world, right? And these differences could affect your results. Similarly, you could have methodological heterogeneity, which means the study type could be different. One could be an observational study, one could be a randomized control trial, one could have a placebo control, the other could have an active control. So when you have substantial clinical or methodological heterogeneity, you should not be combining the results into a meta-analysis, right? You should be stopping with a systematic review and saying, because the study settings or participants were so different from each other, we could not go ahead and combine the results of the studies. We could not do a meta-analysis. Sometimes there is no clinical or methodological heterogeneity, but the results of studies are still different from each other, and that is what we call statistical heterogeneity. Okay, so the results are different, though everything else appears to be similar. So as I just said, if you have substantial clinical or methodological heterogeneity, do not do a meta-analysis. Okay, but if you have statistical heterogeneity, then you need to see. And how do you know if you have statistical heterogeneity? You will run a couple of tests called the chi-square test and the I-square test. And these are tests which tell you whether the results of your studies are substantially different from each other. Okay. Now, why is this important? Because when we combine the results in a meta-analysis and we give weightage to the different types of studies, we have various models of doing it. If there is a lot of heterogeneity, we use something called a random effects model. And that if there is not much heterogeneity, then we can use something called a fixed effects model. Okay. I don't want to get into the details of how it is done. Okay. And it's okay if you don't understand the next slide because it's highly statistical. Basically, a fixed effects model assumes that all studies are estimating the same effect, and the differences in the results are only because of variability in sampling. Okay, and this depends mainly on the sample size of the study. So it believes that larger studies give you more precise results, smaller studies give you less precise results, and that if all studies were infinitely large, they would just show the same result. Okay, that is what a fixed effects model believes in. Whereas in a random effects model, they believe that each study is estimating a different effect, which is not so much affected by sample size. Okay, and this is a more conservative approach. So now I'm taking you back to this forest plot, laryngeal edema in intubated patients, and you can see they've run a test for heterogeneity. It's a chi-square and an I-square. The chi-square test for heterogeneity is significant because the p-value is really, really low. Okay? When you interpret the I-square, anything less than 25% means there is no heterogeneity. 25 to 50 means moderate heterogeneity, and more than 50 means substantial heterogeneity. And this study has 74% I-square, which means there is substantial heterogeneity, and therefore they used the random effects model. So if there is heterogeneity, use the random effects model. They looked at another outcome also, and this was reintubations, right? And for this, when they ran the chi-square, it was not significant. The I-square was only 13%, which means there was not much heterogeneity. And so they used a fixed effects model. So this is how tests of heterogeneity are used to see whether there is substantial statistical heterogeneity between the results of studies, and they decide which model you're going to use. Now, why are the results of studies in a meta-analysis different from each other? And to investigate that, you could do something called a subgroup analysis or a sensitivity analysis. And basically what you do is, out of the studies in the review, you just have a look and see, is there one study whose results are very different from the others? Is there one study whose quality is very different from the others? Does leaving that one study out make a difference? Okay, so you basically categorize studies into subgroups based on important variables, and then do repeated meta-analysis to see whether including or excluding particular studies makes a difference. So this is what they did in this study also. This was when they included all studies. We already saw this result, right? For laryngeal edema, they got an odds ratio of 0.38. And then they excluded one study which had that really poor Gerard score. So the study which had the worst Gerard score, and they got this result. Then they excluded studies which had high-risk patients, okay? And then they looked at various doses of steroid, okay? So for each dose, they did a separate meta-analysis. And so this is how you do sensitivity and subgroup analysis to get various different confidence intervals and odds ratios. Now, so far, we've been talking about taking the results of individual studies and combining or pooling them. And this is what we call aggregate data meta-analysis, because you're just taking the results from published papers. There is something called an individual patient data meta-analysis or IPD meta-analysis. And here what you do is you go one step further, you reach out to authors and you get the raw data for each of their studies. You reanalyze the data within each study. So again, you're not combining the results of all the studies, okay? You're not combining patients across all the studies, but you reanalyze the data yourself. And the advantage of this is you can verify the study quality. So when they send you the raw data, you know what kind of data they have collected. You can verify the results because you know now the data is in your hands. You can analyze and compare the results with what they have published. You can also standardize the outcome. So for example, if a study has captured pain scores on day 2, day 7 and day 10, and they have only published the day 7 scores. Now, if in your meta-analysis you want the day 2 scores, you have it in the raw data. So you can standardize the outcomes across the various studies which were included. But remember, this involves a lot of effort because you need to write to so many authors, get their consent, get the raw data, and reanalyze each study separately. Another type of meta-analysis is known as cumulative meta-analysis. Here what happens is you do an initial meta-analysis, and then every time a new study is published on that topic, you add that to the meta-analysis, which means you're doing sequential meta-analysis every time a new study is published. And this is also known as a pairwise meta-analysis because it's meta-analysis plus new study, and then again meta-analysis plus new study, right? Again, a very, very laborious task, but this could be very useful. And let me show you this example. So this was a paper published in 1992. And this looked at streptokinase versus placebo in myocardial infarction. And they looked at all studies published since 1959 till 1988. Okay. This is the number of patients in each study and the results of each study. And you can see the odds ratios are all over the place, right? Some studies have shown that streptokinase is better. Some have shown that placebo is actually better. So if the dot is on the other side, it favors the control. And if the dot is on this side, it favors the treatment, right? Now somebody decided in 1992 to do a cumulative meta-analysis. And by that, what they did was they first added the results of these two studies. Then they added the result of this study, then this study, and so on. And this is what they found, right? So when they added the result of 23 plus 42. They got a total of 65 patients, and this was the odds ratio. When they added 65 plus the next 167, they got 232 patients, and this was the odds ratio. And what you can see is, as early as 1973, they could have proved rather, that streptokinase was beneficial, because not only the odds ratios, but also the confidence intervals are on the same side of 1, which means it clearly favors the treatment. And no study done after that has changed that result, right? And this means that after 1973, patients should not have been randomized to receive control, because they were actually being harmed by giving them placebo when they should have been getting streptokinase. So this is the benefit of a cumulative meta-analysis. It increases the sample size at each analysis and allows you to prove very, very early on whether a particular treatment is effective or not. If you're interested, you can go back and read this paper. It's a beautiful example of how meta-analysis helps to define treatments. Now, a little bit about some additional resources for those who are interested in doing or reading about meta-analysis. So all of you have heard about the Cochrane network. This is a global network which produces systematic reviews of primary research in healthcare. Okay? And when you go to the Cochrane website, you have several different resources. So you have Cochrane training, you have students' best evidence, okay, you have featured reviews, and it's a beautiful website. You can just navigate and learn so much about systematic reviews. If you want to do a meta-analysis, you'll need some kind of software, right, where you can enter all your data. And one of the best software that you can use is Review Manager, also known as RevMan. Now, this is a free software from the Cochrane collaboration. And when you enter your study details, it will automatically have buttons where you can check for heterogeneity, and then it will automatically run a fixed effects or a random effects and give you your pooled estimate. So you need to do very, very little except entering your study data. Of course, other popular software like Stata and SAS can also run meta-analysis for you. Now, if you're reading a paper or if you're reporting a meta-analysis, you have something called the PRISMA checklist. And PRISMA stands for Preferred Reporting Items of Systematic Reviews and Meta-Analysis. And it tells you exactly what should be reported in every section of a meta-analysis or systematic review. So what should go into the title, what should go into the abstract, what are the points that you need to cover in the methods. If you're appraising systematic reviews and meta-analysis, you could use this tool. It's called the AMSTAR tool, that is the measurement tool to assess systematic reviews. And these are the various domains which come under AMSTAR, and it helps you to check the quality of a systematic review. Has it reported all these domains? Now, before I wind up, I just want to stress over here that we've spoken so much about systematic reviews and meta-analysis being at the apex of the evidence-based pyramid and how they form the highest quality evidence. But you must remember that a systematic review is only as good as the studies that it includes, and so the quality depends on the quality of the included studies. And we have several examples of systematic reviews which were very poor quality. Second, if there is heterogeneity, you may not and you should not be summating the results. So please do not do a meta-analysis, which is a statistical combination, if there is significant differences between the studies in the review. And lastly, keep publication bias in mind. Your search strategy should be very, very thorough. Otherwise, there is a serious chance that you may be missing studies, particularly studies with negative results. And this is a classic example. So in perioperative medicine, these authors looked at meta-analysis and subsequent randomized trials which compared the same interventions. And so they looked at 18 randomized trials and 44 prior meta-analysis, which were looking at the effects of 16 interventions. And what they found was, in most of the cases, the meta-analysis seemed to suggest that an intervention was effective. But the subsequent randomized trial did not prove the same. Okay, suggesting that there was probably some problem with the meta-analysis. And this is just one example that I'm putting up over here. They looked at alpha-2 agonists versus none in major non-cardiac surgery. And when you looked at mortality, randomized trials seemed to suggest that it was better, but sorry, meta-analysis seemed to suggest that it was better, but a subsequent randomized trial did not show that difference. Similarly, when you looked at myocardial infarction, meta-analysis seemed to suggest that alpha-2 agonists were protective, but a subsequent randomized trial did not show that. So be very, very careful when you're reading or interpreting a meta-analysis, because it depends a lot on the quality of the included studies. That was my last slide, and if there are any questions, I'll be happy to take them.
Ankita, do we have some questions in the question answer chat box?
No, sir, not yet, sir.
So I request the participants, if you have any questions, you can mention in the chat, and our experts will be helping to clarify those queries that you have.
Dr. Rakesh Garg?
Yeah.
Yes, sir. So till we get some questions from the attendees, may I just ask Priya Madam, what is her, what is her your take on the statement that meta-analysis is actually comparing oranges with apples? So many times we get to hear that.
Yeah, so that just refers to heterogeneity, which means variability between studies, right? So if you include studies in a meta-analysis which are very different from each other, it means you're comparing apples with oranges, which is not a valid comparison at all. So that's what it means. And again, I can't stress enough on how you should look very carefully at the studies in a systematic review before you decide to combine them, because if they're different from each other, then combining the results does not really make sense.
Okay.
Ankita,
There's a comment that
Ankita, can we enable the this mute for all the participants? They can ask the question directly
Yes,
also.
sir. Yes, sir.
Yeah, please. Thank you.
So Abhijit asks about Revman. It's no longer free. I'm not sure about that, Abhijit. So any statistical software, particularly Stata and SAS, will help you to do systematic reviews, but both of those are not free. In fact, they're quite expensive. I'm sorry, offhand, I can't think of anything else which can be used, but you could search Google and there are plenty of other options.
Ma'am, by the time more questions are coming, we are usually concerned with some amount of the sample size, even for the meta-analysis. You mentioned a little bit. Can you just explore that? At what point, when we do the meta-analysis, we say that the outcome which is coming from the synthesis of the data, that is appropriate to comment conclusively, apart from the bias regarding the sample size?
Actually, you cannot calculate a sample size for a systematic review and meta-analysis because it will depend on how many studies you identify. But the confidence intervals that you finally have for your estimate, for example, the odds ratio, will tell you how precise is your estimate. So if you have very wide confidence intervals, it means your estimate is not very precise and it cannot be relied on. So for example, in this odds ratio, we saw that the odds ratio was 0.4, but the confidence intervals were 0.1 to 0.7, right? Which is a very wide confidence interval. So this cannot be relied on, but as such, there is no way of calculating a sample size for a systematic review or meta-analysis, because when you start out, you don't know how many studies you're going to identify. So you can't really get that preempted.
So can I just add on here?
Yes, Dr. Priyam.
Yeah, just like we do sample size calculation for randomized control trials, nowadays they are suggesting that you can also have some idea about whether to have certainty of the evidence that you have got out of that systematic review, I mean, whether that adequate numbers of participants has been included or not. That method is your trial sequential meta-analysis. And nowadays we are looking more and more number of articles, I mean, meta-analysis who have used that methodology to see whether, that summary statistic that has been obtained or not, how robust it is, or should we wait for some more studies to pour in so that we can have a more, precise estimate of the true effect.
I think Dr. Saikia can take this next question because I'm not really familiar with trial sequential analysis. Abhijit asks, how much is a trial sequential analysis necessary, especially when there are very few studies for analysis? I think you're on mute, Dr. Saikia.
Oh, sorry. Abhijit, you need to use the that statistical software, and you will have to define your boundaries. What boundaries and how much boundary that you define depends on what is the outcome that we are looking at. The way we do sample size calculation for an RCT, suppose we are looking at the difference of incidence of nausea and vomiting between this drug and that drug, then we set a endpoint that we are looking at a difference of suppose 5% difference of incidence or 10% difference of incidence. That has to be set punch in that software, and then ultimately will tell you whether you have met that amount of that number of total number of participants or not.
I think the topic was very well covered. Madam has made each point of the systematic review and meta-analysis in a very simple, lucid way. I'm sure that this will be helping uh, many of us to do the meta-analysis, systematic review and meta-analysis. But more important will be to understand when we read them, because at times I personally believe that reading the last line of conclusion is not sufficient enough for bringing change into a clinical practice. We need to understand a little bit about the various graphs that comes by the synthesis of various data in the meta-analysis. If we just have a look onto it, it gives a very good idea of the various outcomes that has been studied or reported in that systematic review and meta-analysis. So I must acknowledge Madam Dr. Priya Ranganathan, the lucid presentation, and I'm sure it will be helpful. Dr. Priyam, you want to add something?
No, nothing. Thank you so much for this opportunity, and I hope it was useful.
Yeah,
Dr.
sir,
Priyam?
what I wanted to say that not the 1 hour, even 1 week is not sufficient to understand even the basics of meta-analysis. And Madam has done an excellent job. I mean, she has touched upon almost all the relevant things, which can act as a basis or primer to those people who are trying to understand what is a meta-analysis, and they are trying to understand and read what is a meta-analysis. Madam, I must tell you, you have done an exceptionally great presentation. It was such a pleasure to listen to. I could not realize where that 1 hour has gone.
Thank you. Thank you
It
very
was
much.
such a beautiful, clean, and ma'am, it was a pleasure listening to you.
Thank you so much.
I
I would
wish we
suggest
had
that
many
everybody
more
goes back.
questions from there.
Thank you. I would suggest that everybody just goes back and looks at meta-analysis because, as Dr. Rakesh very rightly said, listening to 1 hour theory is one thing, but when you start reading meta-analysis, looking at the graphs, that's when you realize, okay, this was like this, and that's why they did that, and it just comes with years of practice. So,
Uh, Madam, just can I share my screen if it is possible?
absolutely.
Because can I share my screen if it is possible? Because I just wanted to, because I cannot type it on the chat box. Uh, um, Sorry, probably I'm not able to show you the screen. There is
Ankita,
something called a Copenhagen trial, the trial unit. I'm not able to share my screen now. I do not know
Ankita,
what is the problem.
can you allow Dr. Priyam to share the screen, Ankita?
Sorry, is allowed already.
Yeah, Dr. Priyam, just check it.
Okay. Um. Yeah. Can you see my screen?
Yeah, it's clear. Yeah.
Dr. Nair, this is the software that I was talking about. This is the Copenhagen trial unit. This has got their own, explanations as well as how to, utilize their software. It's a free software, as well as they have got their, their resource materials also. So this is the, site where you'll get all your explanation regarding trial sequential analysis. Can I stop sharing my screen?
Yeah, sure, please. Yeah.
Yeah.
I think this is an important topic. So we'll continue with future sessions on maybe more detailed aspect of each of them. And maybe we can repeat it because there are many things that we can take into further model, like sensitivity analysis, sometimes when to choose random effect model or fixed model. Sometimes we use both of them. How to do a trial sequential analysis to say concretely that we don't need further RCTs even, because this is one of the robust model which has been recently being reported for last 2-3 years now, where once you do a TSA trial sequential analysis done, you're very sure that it will not have any errors into it, and it will give you a very conclusive that you don't you need further RCTs. Obviously, once you have when you have done the risk of bias analysis, as madam has mentioned. So there are many other things, and sometimes even when not to do meta-analysis, because sometimes when you do these studies, you will find that there are a lot of things which madam mentioned in a couple of slides, wherein you will say let it be a systematic review only, and uh, meta-analysis will not be desirable, because maybe that you have different objectives, you have different outcomes, they may not be corroborative, there may be so many heterogeneity. So there are many other nitty-gritties. Once we understand the basic aspect, maybe subsequently SOPSI will arrange as per the need of participants. If they want, we can have more focused studies, and how to look for various nitty-gritties like the size of the diamond, it is crossing the line of no effect, and so on and so forth, so that we can understand by looking at those events. So once again, thank you so much. Thank you, Dr. Priya, for a wonderful session. I also thank Dr. Priyam Saikia, who is one of the wonderful researcher, and he has been associated with the journal, contributing a lot. And thank you to our president, SOPSI, Dr. Josna Goswami. Thank you, Dr. Anjali Pingle, who has been very putting a lot of effort for these webinars for the last 30 weeks now. And thank you, SOPSI, for giving this opportunity. Thank you so much. Thank you, everybody.
All right. Thank you so much, everyone, for your valuable time and for being with us. Hoping to meet you again on this platform very soon for any other next sessions. With all your permissions, we conclude here. Thank you. Bye.